Now with this, we will proceed for our next lecture. Welcome, sir. Now we'll proceed for the next lecture. It will be on, we all are facing pandemic of COVID-19. So next lecture will be on MCCD in presence of COVID-19. For this lecture, I would like to call upon Dr. Rajesh Bardale, Professor, Department of FMT, Government Medical College, Miraj. It's my pleasure to introduce him. Dr. Rajesh Bardale, MD Forensic Medicine, is presently working as Professor, Department of Forensic Medicine, Government Medical College and Hospital, Miraj, Maharashtra, India. He did his MBBS from Government Medical College, Nagpur, and MD Forensic Medicine from Indira Gandhi Government Medical College, Nagpur. He has published about 90 research papers in international, national, and state journals. He is an executive member of Medical Legal Association of Maharashtra. He has published a book titled Principles of Forensic Medicine and Toxicology. Third edition of this book is recently published, including CBME format and lots of photographic illustrations. So we are eager to hear you from sir. Thank you, sir. Please proceed for your lecture.
Sir, you are not audible. Audible.
Excuse me, sir.
Yeah.
Yeah,
Yes. I'm audible.
Yeah, sir. Yes.
So importance of MCCD of COVID-19. Now the importance has been explained by other research faculties, so I will not go into detail in it. But as far as COVID-19 is concerned, it is important to measure the public health impact caused by COVID-19. Similarly, it will help, the data generated will be help to timely intervention and protect the community. Now, before proceeding regarding MCCD, we should know certain terms. What is positive, whether symptoms are present, and what should be the underlying cause. So if the RT-PCR test or rat test is positive and there is no symptoms, it is a confirmed case of COVID-19. So we can label it as an underlying cause of death as a COVID-19. If the test is positive and the symptoms are present, then confirmed case of COVID-19 documented as underlying cause of death. If the test is positive, patient has a comorbid conditions like heart disease, asthma, COPD, like that, then it is a confirmed case of COVID-19 and it can be documented as an underlying cause of death in a line C.
Excuse me, sir.
Yes.
Your slides are not visible. We'll just wait for a minute and start sharing.
Are no visible?
No, not yet.
Is it visible now?
No, sir.
I think Chandrakant has not closed his slides.
That's नहीं
So is it now visible?
Yes, yes, now it is visible, sir.
We should know the definition of certain terms like test, whether the test is positive or negative, whether the symptoms are there or there is absence of symptoms, and what could be the diagnosis. If the test is positive and there are no symptoms, it is a confirmed case of COVID-19, and we can label it as an underlying cause of death, COVID. If the test is positive and symptoms are present, again it is confirmed case of COVID-19, and we can document it as an underlying cause of death. If the test is positive and the patient is having comorbid conditions like heart disease, asthma, or COPD, then we can again label it as a confirmed case of COVID-19, and we can place this as an underlying cause of death at line C. If the test is negative, the symptoms are present, then clinically and epidemiologically, we should mention as a case of diagnosed case of COVID-19. So here the test is negative, but the symptoms are present. So based on clinical and epidemiological findings, we are diagnosing the case as a COVID-19. Now here there are certain occasions where test is awaited, the patient dies, and we have to certify the MCCD. In this condition, the test report is awaited, the symptoms are present. Now we have to write suspected COVID-19 in the underlying cause of death. Many times we send a sample to lab, but somehow the test comes inconclusive. Already the patient is dead and shifted to mortuary, so it is difficult to take another samples. In this condition, based on presence of symptoms, now we will label this case as a probable case of a COVID-19. So accordingly, we will have the coding and we will have the underlying cause of death. It is a confirmed case, then it should be documented as underlying cause of death as a COVID-19. So as we know, we have two parts, part one and part two. Then part one have immediate cause of death, then we have antecedent cause of death, and we have underlying cause of death. Now COVID-19 is known to cause ARDS or pneumonia or DIC. So it should be recorded in line A or line B, and COVID-19 as an underlying cause of death at line C. As far as possible, avoid using term respiratory failure as it is a mode of death. Now the time interval between the presumed onset of symptoms and death should be mentioned, and it should be approximate. Terms can be used such as hours, days, weeks, or years. Now part two is the contributing conditions which increase the risk of respiratory infections and may lead to complications, but does not lead directly to the death. So in a given patient, there are maybe multiple comorbid conditions, but record only those conditions that had contributed to the process of death. So here we are taking an example, a 40-year male diagnosed with COVID-19. Now here immediate cause of death, antecedent cause of death would be there. So since the patient is a diagnosed case, we will place COVID-19 as the underlying cause of death. Then acute respiratory distress syndrome at B, that is antecedent cause of death, and respiratory acidosis as a immediate cause of death. Now one should mention the interval between onset and death. So in case of immediate, it is 2 days. Then for ARDS, it is 3 days, and COVID-19, 7 days. Now in this given example, there are no comorbidities. So we have left the column part 2 as a blank. In the second example, a 60-year male, father of COVID-19 patient, and a known diabetes individual presented with influenza-like illness and died. Test for COVID is not available. Now what to do? So in case of underlying cause of death, we will write COVID-19 suspect. Then at antecedent cause, influenza-like illness, and in line A, that is immediate cause of death, we will mention acute respiratory distress syndrome. Now, since the person is having comorbidity, we'll write diabetes mellitus in part 2. And these are the codes which are for statistical purpose. For confirmed case, it is UO 7.1. For suspected, it is UO 7.1. Now, this is third example. A 50-year-old female completed chemotherapy for breast cancer, admitted with breathlessness and developed shock and died. The COVID test is positive. Now, what would be the underlying cause of death? Here again, we will place COVID-19 as underlying cause of death. Then we will place pneumonia as an antecedent cause, and then DIC as an immediate cause of death. Now, since the lady had breast cancer, we will put this breast cancer in a part 2, that is other significant conditions that has contributed to the death but does not lead directly to death. So, manner and place of death already, previous speakers have already highlighted the manner. Now, death due to COVID is a natural, so eventually we have to enter it as a natural. However, there are certain situations where a person may commit a self-harm or cause a self-harm. For example, a person may hang himself, or a person may drink a poison or have a cut throat. At our hospital, we have 2 cases, one cases of cut throat and one cases of hanging. So in that case, the COVID-19 will be in the part 2. That is a contributory cause of death, but does not lead directly to death. Here, the hanging will be immediate cause of death, like that. Place usually the COVID deaths are occurred in hospital, so we will issue form number 4. If a doctor is certifying the person at a home, then he or she should use form number 4A. Now we have very good software prepared by ICMR and NCDIR, that is called as eMOR software. Now that is freely available at the National Center for Disease Informatics and Research. Have developed a software for recording and reporting of cause of death. It means it contains form number 4 or 4A and form number 2, because it will record the cause of death as well as it will report the cause of death. Now, as per national standards laid down by the Office of Registrar General of India. Now, this software can be used by government hospital as well as private hospital, or even general practitioners can use this software, provided they have to register with National Center for Disease Informatics and Research. So it will have form number 4 and 4A, and similarly form number 2. The institute should contact with their given email, and the ICMR and NCDR will provide all the support needed for that particular installation of software and running of software. Now, this particular software is available at ncdirindia.org/e-more/. So one can download this software from this particular site. So in nutshell, we have to identify whether a given case is a confirmed COVID case, or whether it is a suspected COVID case, or whether it is a clinically epidemiologically COVID-19 case, and accordingly we have to use that COVID-19 as an underlying cause of death. So this is about use of MCCD in COVID-19 death. So thank you very much.
Thank you, sir, for your very informative lecture, and you have given the practical aspects of death in the COVID cases. Also, you have explained the use of ICMR, NCDIR, eMOR software and how it should be used by institutions. So we are very thankful to sir.